Popular medicines that may affect memory or increase dementia risk. Medicines save lives, control pain, improve sleep, reduce anxiety, and help people manage long-term health conditions. However, some commonly prescribed and over-the-counter medicines can also interfere with memory, concentration, and clear thinking. In certain cases, the cognitive effects are temporary and improve when the dose is reduced or the medicine is changed. In other cases, long-term or cumulative exposure has been associated with a higher rate of dementia in observational research. The wording here is important. Most of these medicines have not been conclusively proven to cause dementia. An association does not necessarily mean that the medicine itself is responsible. The illness being treated, a person's age, genetics, lifestyle, other medications, and early undiagnosed dementia may all influence the results. Nevertheless, the evidence is strong enough for doctors, pharmacists, and patients to take medication-related cognitive effects seriously, particularly in people over 65, those taking several medicines, and anyone already experiencing memory problems. Let's get into it. Dementia, delirium, and ordinary forgetfulness are not the same. Dementia is a progressive syndrome involving a continuing decline in memory, reasoning, language, judgment, or other cognitive abilities that interferes with everyday life. Medication-related cognitive impairment can look similar, but it may develop much more quickly. A person might suddenly become confused, sleepy, disorientated, forgetful, or unable to concentrate. This acute state may be delirium, which can be triggered by medicines, infections, dehydration, pain, or metabolic disturbances. Delirium can appear over hours or days, whereas most forms of dementia develop over months or years. Medicines can therefore affect the brain in several different ways, causing temporary drowsiness or poor concentration, triggering delirium, worsening the symptoms of existing dementia, producing cognitive impairment that resembles dementia, or possibly contributing to long-term dementia risk after heavy or prolonged exposure. A proper medical assessment is essential because medication-related cognitive impairment may sometimes be treatable or reversible. 1. Anticholinergic medicines. The clearest and most consistent evidence concerns medicines with strong anticholinergic effects. Anticholinergic medicines block acetylcholine, a chemical messenger involved in attention, learning, memory, muscle activity, and communication between nerve cells. Because acetylcholine is particularly important to cognitive function, blocking it can cause confusion and memory difficulties. Anticholinergic effects are found across many different categories of medicine rather than in one single drug group. Examples can include older sedating antihistamines, some bladder control medicines, tricyclic antidepressants, some Parkinson's medicines, certain antipsychotics, some anti-sickness medicines, muscle relaxants, and medicines used to treat intestinal cramping. NICE notes that commonly prescribed medicines with antimuscarinic or anticholinergic effects may contribute to cognitive impairment and recommends considering anticholinergic burden during the assessment and treatment of dementia. Large UK study results. A major 2018 study published in the BMJ examined the medical records of more than 40,000 people diagnosed with dementia and compared them with more than 280,000 people without dementia. The researchers assessed anticholinergic prescriptions issued between 4 and 20 years before diagnosis. Strong anticholinergic exposure was associated with a higher rate of dementia, particularly for certain antidepressants, bladder medicines, and Parkinson's medicines. Strong anticholinergic use, 15 to 20 years before diagnosis, was associated with approximately 17% higher odds of dementia. For strongly anticholinergic antidepressants, the odds were around 19% higher, while strongly anticholinergic bladder medicines were associated with approximately 27% higher odds. These figures represent relative changes in risk, not a prediction that everyone taking these medicines will develop dementia. Cumulative exposure study results. A 2015 prospective study followed 3,434 adults aged 65 and over who did not have dementia when the research began. During an average follow-up period of approximately 7 years, 797 participants developed dementia, including 637 who developed Alzheimer's disease. Compared with people who had little or no exposure, those with the highest cumulative exposure to strong anticholinergic medicines had roughly a 54% higher rate of dementia. The most frequently used medicines included tricyclic antidepressants, first-generation antihistamines, and bladder antimuscarinics. The apparent dose-response pattern is significant. The greater the cumulative exposure, the stronger the observed association. However, this was still an observational study. It could demonstrate a relationship but could not prove that the medicines directly caused dementia. 2. Older antihistamines and nighttime remedies. Some older antihistamines readily enter the brain and have strong sedating and anticholinergic effects. Examples include diphenhydramine, chlorphenamine, promethazine, and hydroxyzine. Depending on the country and product, these ingredients may be found in medicines for allergies, itching, colds, travel sickness, and sleep. Diphenhydramine is especially important because it is sometimes included in over-the-counter nighttime painkillers or sleep aids. Someone may take it regularly without realizing that it has a strong anticholinergic effect. Possible cognitive side effects include short-term memory problems, slowed reaction times, poor attention, daytime drowsiness, confusion, blurred vision, difficulty urinating, and delirium in vulnerable older adults. A study involving hospitalized older patients found that diphenhydramine exposure was associated with a significantly greater risk of cognitive decline and behavioral disturbance. The researchers also observed a dose-response relationship, meaning problems became more likely as exposure increased. This does not mean that occasional antihistamine use inevitably causes dementia. The concern is greatest with frequent use, stronger doses, advanced age, existing cognitive impairment, and the use of several anticholinergic medicines together. Newer, less sedating antihistamines may have fewer cognitive effects, although suitability depends on the individual and should be discussed with a pharmacist or doctor. 3. Bladder control medicines. Overactive bladder and urinary urgency are common, particularly in later life. Several treatments work by blocking muscarinic acetylcholine receptors. Examples include oxybutynin, tolterodine, solifenacin, darifenacin, fesoterodine, and trospium. These medicines can reduce bladder contractions, but some can also interfere with acetylcholine activity in the brain. Oxybutynin is frequently highlighted because it has strong anticholinergic activity and can enter the central nervous system. Possible effects include confusion, drowsiness, memory impairment, and delirium. The 2018 UK study found that strongly anticholinergic urological medicines prescribed 15 to 20 years before diagnosis were associated with approximately 27% higher odds of dementia. A nationwide Danish study published in 2025 also found that anticholinergic bladder medicines were associated with a higher rate of dementia when users were compared with non-users. However, comparisons between different bladder treatments produced more complicated results, illustrating how difficult it is to separate the medicine's effects from the underlying condition and other health factors. People should not simply stop bladder treatment. Untreated urinary symptoms can severely affect sleep, independence, dignity, and mental health. A clinician may instead consider bladder training, fluid timing strategies, reviewing caffeine and alcohol, treating constipation, pelvic floor exercises, lowering the dose, or selecting a treatment with less cognitive impact. 4. Tricyclic antidepressants. Tricyclic antidepressants are older medicines that remain useful for depression, nerve pain, migraine prevention, and sleep problems. Examples include amitriptyline, imipramine, clomipramine, docilipin, and doxepin. Many tricyclic antidepressants have anticholinergic and sedating effects. They may cause forgetfulness, slowed thinking, confusion, dry mouth, constipation, blurred vision, dizziness, and difficulty passing urine. Amitriptyline is particularly common because low doses are often prescribed for nerve pain, migraine, or sleep rather than depression. In the 2018 BMJ study, strongly anticholinergic antidepressants showed one of the clearest long-term associations with dementia. The relationship was present even when prescriptions had been issued 15 to 20 years before dementia diagnosis. Depression itself is also associated with dementia risk and may sometimes be an early feature of developing dementia. This makes causation difficult to establish. The finding does not mean antidepressants as a whole cause dementia. Many modern antidepressants have much lower anticholinergic activity, and adequately treating serious depression may improve concentration, sleep, functioning, and quality of life. 5. Benzodiazepines. Benzodiazepines are prescribed for anxiety, severe distress, insomnia, muscle spasms, alcohol withdrawal, and seizures. Examples include diazepam, lorazepam, temazepam, clonazepam, alprazolam, and oxazepam. These medicines enhance the action of gamma-aminobutyric acid, or GABA, which reduces activity in the nervous system. They can cause immediate cognitive effects including sedation, impaired short-term memory, slower information processing, reduced coordination, poor concentration, and confusion. Older adults may be especially sensitive because medicines can remain in the body for longer and because the aging brain is more vulnerable to sedative effects. What does the dementia research show? Some observational studies and earlier meta-analyses reported higher dementia rates among long-term benzodiazepine users. However, the overall evidence is disputed. A 2023 Umbrella Review examined 5 meta-analyses covering 30 studies. Reported associations ranged from approximately 38% to 78% higher dementia risk, but the review judged the evidence to be weak and the methodological quality of the underlying studies to be low. A 2024 population study found no statistically significant overall association between benzodiazepine use and dementia. The reported hazard ratio was 1.06 with a 95% confidence interval of 0.92 to 1.25. A 2025 systematic review similarly found no strong statistically significant link. Chronic use was associated with a hazard ratio of 1.17 for all-cause dementia, but the confidence interval crossed 1.0, meaning the result could have occurred by chance. The analysis found no increased rate of Alzheimer's disease. One major difficulty is reverse causation. Anxiety and sleep disturbance can develop during the early stages of dementia, years before a formal diagnosis. Benzodiazepines may therefore appear to predict dementia because they were prescribed for its earliest symptoms. The most balanced conclusion is that benzodiazepines can clearly impair memory and cognition while they are being taken, especially at higher doses and in older people. Whether they independently cause dementia remains unproven. Benzodiazepines must not be stopped abruptly after regular use. Sudden withdrawal can cause severe anxiety, insomnia, confusion, seizures, and other dangerous symptoms. Any reduction requires medical supervision. 6. Sleeping tablets and Z-drugs. Non-benzodiazepine sleeping medicines include zopiclone, zolpidem, and zaleplon. Although chemically different from benzodiazepines, they affect similar GABA-related systems in the brain. Possible problems include next-day drowsiness, memory gaps, slowed reactions, confusion, unusual behavior while partly asleep, falls, and dependence. Some observational studies have linked hypnotic use with higher dementia rates. However, chronic insomnia itself may be associated with cognitive decline, depression, vascular disease, and early neurodegenerative changes. It is therefore difficult to determine whether the medicine, the sleep disorder, or another underlying condition explains the relationship. For most people, these medicines are intended for short-term use. Persistent insomnia should normally prompt investigation of factors such as sleep apnea, depression, anxiety, pain, alcohol consumption, restless leg syndrome, or poor sleep routines. 7. Opioid painkillers. Opioid medicines include codeine, tramadol, morphine, oxycodone, fentanyl, buprenorphine, and hydromorphone. They may be essential for severe acute pain, cancer pain, palliative care, and selected chronic pain conditions. Opioids can nevertheless affect attention, alertness, and memory. Higher doses may cause sedation, slowed thinking, confusion, hallucinations, delirium, breathing suppression, and reduced oxygen delivery during overdose. The long-term dementia evidence is still developing. A 2025 UK Biobank analysis found that regular opioid use was associated with approximately 20% higher risk of all-cause dementia and 49% higher risk of vascular dementia. Another 2025 study found that opioid exposure and duration were not generally associated with dementia, although high-dose use was associated with greater memory decline and a higher estimated probability of dementia. A recent systematic review concluded that regular opioid use may be associated with a higher dementia rate, but warned that the results should not be interpreted as proof of causation. These studies face substantial confounding. People receiving long-term opioids may also have chronic pain, reduced mobility, disrupted sleep, depression, serious illness, or social isolation, all of which can affect cognitive health. The most established neurological risks of opioids remain sedation, delirium, dependence, and overdose rather than proven direct causation of dementia. 8. Antipsychotic medicines. Antipsychotics include medicines such as haloperidol, risperidone, olanzapine, quetiapine, chlorpromazine, and clozapine. These medicines are important in the treatment of schizophrenia, psychosis, mania, and some severe behavioral disturbances. Certain antipsychotics can produce sedation, slowed thinking, reduced attention, movement problems, and anticholinergic effects. Antipsychotics are not generally described as medicines that cause dementia. The larger concern is that they may worsen confusion or create serious risks when used in someone who already has dementia. In older people with dementia, antipsychotics can increase the risk of stroke, falls, excessive sedation, and death. They may still be used in carefully selected circumstances, for example, when severe agitation, aggression, or psychosis creates an immediate risk of harm, but treatment should be regularly reviewed. A person taking an antipsychotic for schizophrenia, bipolar disorder, or another serious condition should never stop it because of dementia fears without speaking to the prescribing specialist. Relapse of psychosis or mania can be extremely serious. 9. Anti-seizure medicines. Anti-seizure medicines are used not only for epilepsy but also for nerve pain, migraine, mood stabilization, and anxiety. Examples include topiramate, valproate, carbamazepine, phenytoin, phenobarbital, gabapentin, and pregabalin. Some can impair word finding, attention, processing speed, memory, balance, and alertness. Topiramate is particularly well known for causing word finding and concentration difficulties in some patients. Phenobarbital and other strongly sedating medicines may also have significant cognitive effects. These symptoms do not automatically indicate dementia. They may be dose-related and can sometimes improve after a carefully supervised adjustment. Seizures themselves, brain injuries, stroke, and the underlying neurological conditions being treated may independently affect dementia risk. This makes long-term medication studies difficult to interpret. Anti-seizure medicines must not be stopped suddenly because doing so may trigger dangerous seizures. 10. Proton pump inhibitors. Proton pump inhibitors, or PPIs, reduce stomach acid and are commonly used for reflux, stomach ulcers, and protection from gastrointestinal bleeding. Examples include omeprazole, lansoprazole, pantoprazole, esomeprazole, and rabeprazole. Earlier observational reports raised concerns about a possible relationship between long-term PPI use and dementia. Proposed explanations included vitamin B12 deficiency, magnesium deficiency, vascular changes, and possible effects on amyloid metabolism. However, better quality reviews have generally not confirmed a convincing causal relationship. A 2023 meta-analysis found no clear evidence that PPI treatment increased dementia risk. A 2024 genetic analysis found no robust evidence that PPIs cause dementia and concluded that clinically justified PPI treatment should not be restricted solely because of dementia fears. A broad review of systematic reviews and meta-analyses published more recently found that most analyses showed no association, although the overall certainty of evidence remained low. PPIs should still be reviewed periodically because unnecessary long-term treatment can carry other risks. However, headlines claiming that omeprazole or similar medicines clearly cause dementia go beyond the current evidence. 11. Corticosteroids. Corticosteroids include prednisolone, prednisone, dexamethasone, and hydrocortisone. They are used to treat inflammation, autoimmune disorders, asthma, severe allergies, and many other conditions. High doses can sometimes cause insomnia, agitation, mood changes, depression, mania, psychosis, confusion, and memory problems. These effects can be dramatic, especially during high dose or prolonged treatment, but they are not usually equivalent to progressive dementia. Symptoms often improve when the dose is reduced under medical supervision. Long-term steroid exposure can also contribute indirectly to vascular risk by worsening blood pressure, blood sugar, weight, and sleep. These factors may influence long-term brain health. Corticosteroids should not be stopped suddenly after extended use because the body may have reduced its natural steroid production. The importance of total anticholinergic burden. A person may not be taking one obviously high-risk medicine. Instead, they may be taking several medicines that each have mild anticholinergic effects. For example, someone might use an antidepressant, a bladder medicine, an antihistamine, an anti-sickness tablet, and a nighttime pain remedy. Individually, each prescription may appear reasonable. Together, they can create a substantial anticholinergic burden. Older people are particularly vulnerable because they may metabolize medicines more slowly, have reduced kidney or liver function, take more prescriptions, have a more permeable blood-brain barrier, and have lower neurological reserve. NICE recommends investigating reversible causes of cognitive decline, including medicines associated with increased anticholinergic burden, before confirming a dementia diagnosis. Why observational studies can be misleading. Most evidence connecting medicines with dementia comes from observational research rather than randomized clinical trials. Long-term randomized trials that deliberately expose people to potentially harmful medicines for many years would usually be unethical and impractical. Researchers therefore study health records and compare medicine users with non-users. This introduces several problems. confounding by indication. The illness for which the medicine was prescribed may itself be associated with dementia. For example, depression may precede dementia. Insomnia may be an early symptom. Chronic pain may reduce activity and sleep quality. Urinary problems may be associated with neurological disease, and anxiety can emerge during early cognitive decline. Reverse causation. A medicine may be prescribed to treat the earliest symptoms of an undiagnosed dementia. Researchers may then mistakenly conclude that the medicine caused the condition. Differences between users and non-users. People taking long-term medication may differ in age, health, income, physical activity, alcohol consumption, smoking, education, and access to healthcare. Researchers attempt to adjust for these factors, but no statistical model can remove every possible difference. Prescription records do not prove consumption. A medical record may show that a medicine was prescribed, but not whether it was taken every day, taken occasionally, or never taken at all. For these reasons, phrases such as associated with, linked with, and correlated with are more accurate than saying that a medicine definitely causes dementia. Warning signs that medication may be affecting cognition. A medication review should be considered when someone develops new or rapidly worsening forgetfulness, unusual daytime sleepiness, difficulty following conversations, disorientation, hallucinations, unexplained falls, slurred speech, poor coordination, sudden personality changes, agitation, or confusion that began after a new medicine or dose increase. Sudden confusion should be treated urgently, particularly when accompanied by weakness, facial drooping, speech problems, severe headache, fever, breathing difficulty, chest pain, or loss of consciousness. What patients and families should do: the safest response is not to panic and not to stop medication independently. Instead, make a complete medication list. Include prescriptions, painkillers, antihistamines, sleep aids, herbal remedies, and medicines bought online or from a supermarket. Ask for a structured medication review. A GP, prescribing clinician or pharmacist, can check for anticholinergic burden, sedative combinations, duplication, and drug interactions. Ask whether the medicine is still necessary. Some prescriptions continue for years, even though the original problem has resolved. Discuss dose and duration. The lowest effective dose for the shortest suitable time may reduce risk. Ask about alternatives. Alternatives may include a less anticholinergic medicine, psychological therapy, physiotherapy, bladder training, sleep treatment, or non-drug pain management. Do not stop high-risk medicines abruptly. Benzodiazepines, opioids, corticosteroids, antidepressants, antipsychotics, and anti-seizure medicines may require gradual reduction. Investigate other causes. Cognitive symptoms can also result from infection, depression, sleep apnea, thyroid disease, vitamin B12 deficiency, dehydration, alcohol, stroke, hearing loss, or uncontrolled diabetes. Final conclusion. The strongest research-based concern surrounds long-term cumulative exposure to medicines with strong anticholinergic properties. Older antihistamines, some bladder medicines, and certain tricyclic antidepressants have repeatedly been associated with cognitive impairment and higher dementia rates, especially when used heavily or in combination. Benzodiazepines, sleeping tablets, and opioids can clearly impair memory and alertness, but evidence that they directly cause dementia remains mixed and vulnerable to confounding and reverse causation. Claims involving proton pump inhibitors are weaker still, with most recent reviews failing to establish a convincing causal relationship. The central message is not that these medicines are universally dangerous. Each may provide genuine and sometimes essential benefits. The lesson is that cognitive effects should be recognized, total medication burden should be reviewed, and long-term treatment should not continue automatically without reassessing risks and benefits. Anyone concerned about memory changes should speak to a GP, pharmacist, or prescribing specialist. Medicines should be reviewed carefully, not stopped suddenly on the basis of an alarming headline. Drop us your thoughts in the comments. Let's talk it out with healthy discussion. Thank you all for watching. See you all next time.